Dr. Thames?
Well, that was a great answer, Dr. Hill. I look at sociocultural factors very similarly. I try to think of it through the lens. We all can look at the same thing, but have a different experience. And that experience is shaped largely on our prior experiences. And I know for categorical reasons, we talk about race in certain ways, but there's a lot of diversity within race. There's a lot of diversity within Black people. And so we talk about this often in research as if we're just kind of all the same thing. And the way I try to approach the sociocultural factors is not just, oh, is this person Black? Is this person, Hispanic, or whatever the category is? It's what has your life course experience been? What kind of schools did you go to? Growing up, what kind of resources did they have? Was there an emphasis on high stakes testing? What kind of traumas and adversities have happened from childhood that may be intergenerational? All of those are factors that sort of shape brain development and how we perceive and think about the world. And also there is the sort of systemic issues with regard to how systems and policies are put into place and who puts those policies into place. And so I think about it in my work. I really hope to see moving forward that there are more representation of leaders pushing the frameworks that we are as researchers are studying, because sometimes the people studying this field haven't really experienced this. So then how do you learn, from any of it? So in all of my work, that's probably a long-winded answer, but that's how I try to look at it.
That was great. Thank you very much for that. That's right. Yeah, that was wonderful. And something that really resonated with what you just said, Dr. Thames, to me was this issue of within group heterogeneity. So that just because we're talking about the Black population, there is a wide range of experience in all levels. And even on this panel here, very different experiences. I'm Afro-Latinx. We have people from different parts of the United States here, different geographic. We have the South is well represented with Dr. Thorpe, and we have so many different unique experiences because we come from different threads of the African diaspora. But often we are treated as one monolithic group, and that's why when we can't figure out why healthcare providers aren't getting it right, why the researchers aren't getting it right, there's really a lack of attention, I think, to that point. So I really appreciate that you brought that up as well. Dr. Thorpe, in terms of operationalizing sociocultural variables, do you have anything you want to add to that before we move on?
No, I think it was very well covered.
Great, wonderful. And in terms of these variables that we've just talked about, so within group variance, education, adversity, SES, I think I heard a culture, so acculturation maybe as well. When we think about how to apply these sociocultural variables to research with Black men in Alzheimer's and related dementias, are there any certain variables that you think are really important that we need to be looking at and maybe we're not?
Well, I think we don't know. I'll be honest, I don't know, because I think that in order for me to know what needs to be studied, I need to get the experience from Black men who are in the community. And I think we don't do enough of that in our research. We come up with scales and think about the psychometrics and trying to look at a particular construct, but we never ask people from the community who we're trying to get information from whether or not this is even relevant. So I guess to answer that question, I'm going to say no. I won't know until I talk to enough Black men who I feel are representative across different geographic areas.
So yeah, so I totally agree with that. I also just want to add with regard to the social cultural factors, particularly as it relates to Black men. One, education. I think the education and the way in which we measure it is problematic in and of itself. And so thinking about rethinking or reimagining what education really means, and particularly when we take this life course perspective and this within group heterogeneity, I think we need to really think about move beyond just education and the different classifications that we have, or expand the classification for which we know African-American men occupy. For example, oftentimes we don't think about, or it's not valued, a vocational degree as high as valued as a bachelor's degree, when we know that many times with the people that are in our studies, or the people we're trying to understand, have that. We need to appreciate that and measure that. And the other thing I think we need to understand, particularly from a life course perspective, understand the impact of the desegregation of schools and how that impacted the education, and then the education quality of which, when we're thinking about Black men and as it relates to men's health or brain health.
Dr. Hill?
All great points that, in addition, to those is this concept of John Henryism, Dr. Sherman Thames that developed that in the 80s, and it's higher for COVID, in the face of structural and interpersonal discrimination. John Henry was this fictional character, I think, who literally worked himself to death, so the idea of, raging against the structure, in however ways that, a Black man would, from a sociocultural perspective, is really interesting. And just wanting to know if that's relevant to April's point, relevant in today's society. Things change and the ways that people adapt and cope to stress, like discrimination, change.
That's right. Okay, thank you very much. Okay, next question. So there are a number of multi-site, huge cohort studies examining Alzheimer's and related dementias and cognitive aging across the country. I can think of a number of them. Y'all know many of them as well. From those big studies, how well do you think that the current studies out there studying this are looking at sociocultural factors and really incorporating this health disparities research framework into the work? And we're talking about, studies with thousands of people, lots of funds going to those studies. What do you think?
So, yeah, I'll take this. I'm okay with it. So I showed this morning I showed that one of the biggest biggest problems we have, particularly with Black men, is this underrepresentation in research. And I still think that's the same. So we have this small sample size of Black men in research. And then while I don't know the objective of each one of those large studies, I'm willing to hedge, though, that many of those studies don't, if they're not, the research objective is not actually to learn and advance our understanding around Black men, then I'm convinced that they may not have all of the appropriate social cultural factors in there that would help us tease out and have a better understanding of Black men's brain health.
Great, thank you very much. That was not an easy question.
Well,
Go ahead.
Probably not as much, because there's necessary, I don't know if Roland said this, but qualitative research that, Dr. Thames mentioned earlier, that we got to understand, take a deeper contextual dive into understanding the needs for Black men, and not just picking a scale off the shelf, to apply it to this population. So that could be an opportunity for funders for this particular, really all disproportionately affected population.
And I just want to add that a lot of these large scale studies, they are so focused on recruiting the population that they basically say, okay, we're going to hire a study coordinator who's, looks like the people, and have them come and recruit all these people into the study. But there is essentially no training about how do you do collaborative, partnered, engaged work. It's just, come recruit the people into our study. We're going to do the same protocol that we've been doing for all our other studies on white people, but we're just going to now apply it to this different population. And I think that's very problematic.
So one other thing that I was just prompted when Dr. Tim eloquently talked about recruitment. Oftentimes in funding announcements, and I've been hearing this all day, and I've been hearing it for the last year and a half, there's been this major emphasis on recruitment, I have not heard nary, yes, I said nary word about retention. And I think retention is just as important in recruitment, because if you're trying, if the goal, I hope the goal in these studies isn't just to follow them and get one shot at time. If that's the case, then it's a different conversation. But if we're trying to follow these people and have a better understanding, I don't see a lot of talk and discussion going on around retention, and people don't budget for retention. But you get them in the study and be like, oh, they here, how are you going to engage them? And for Black men, you're going to have to keep them engaged, right? And so how are you going to keep them engaged? And where's the money to keep them engaged and for retention? So I would like to think about, for us to think about having monies for retention. And when you get them in the study and recruit them, don't think that's the end all be all, because I can think about what Dr. Thames just said about now trying to understand some of those lived experiences when you got there, and now operationalizing what is truly social culture about this group through the lived experience. I don't woke up now. I'm good. I'm good. I'm up now. I'm
Okay,
up now.
That lunch bug is shaking
No,
up. All right.
Dr. Thames, she just prompted me.
All right,
Thank
very,
you.
very
Thank
good, very good. Well, so I'm gonna mention that the work on retention, it needs to start coming, but a little bit is being done, and I'm gonna put a quick plug in for a grant that myself and Dr. Rachel Nasheni, my collaborator, and Dr. Hill, that we're working on, which is focused just on retention in Black populations within a study called, it's dedicated to Genentech Health Equity Fund, and we're looking at just retention with Black men in that, or Black populations in that study, and we're very excited about that and taking a community-based approach. But I think ours is maybe one of the only studies I've ever heard of that's focused on retention. Carl, have you heard of others?
Yeah.
Dr. Hill?
I think so. Yeah.
Yeah, so I know there's one, because we're trying to do it right now, but
Bless you.
thank you.
Bless
But it's rare. It's really rare. And I would actually take it one step further, Dr. Thorpe, because we do have to work on retention. We do have to work on recruitment as well. But then we have to make sure that the studies we're putting people into, especially Black men and all these diverse populations, are ready to receive them in all the ways that these studies need to come correct and be ready to receive them. What do you think about that?
No, I think that's very important. I think not only being ready to receive them, but I want to expand on being ready to receive them. Being ready to receive them, and from my perspective, is also offering them benefits throughout the project, the research, as opposed to waiting to get to the end, right? I think that's another thing that I think needs to happen more often in these studies, because I think it's very crucial. Because as I know if I was in a study as a Black man, if I feel like that, oh, you got my information and nothing else is going to happen, I'm going to stop engaging. And so I think it's important to engage and have benefits along the way. Particularly if we're thinking about a year or two down the road for a final outcome, I think we need to have some outcomes earlier, some benefits and some small wins, so that we can engage the Black men that stay in the study. It's marketing 101, Iris. If you like something, you'll tell 10 people. If you dislike somebody, you tell 10,000 people. So you need to make sure what we're doing is in our best interest for Black men.
That's right.
And Dr. Thorpe just got me thinking too about how we communicate the results. I often, I have to refrain from getting really angry when I'm at conferences and I listen to some talks, because of the way that I hear these research results being represented, and it's so pathologizing. And I think I'm personally really tired of it. I don't want to hear about how Black people perform lower, they have worse health conditions. The community doesn't want to hear that either. They really don't. So I think we need to think about a thoughtful way of communicating findings that stop pathologizing people.
So Dr. Tom, you don't have to worry about this crowd doing this, because we took a pledge together today. Don't y'all remember the pledge we took? We took a pledge, so you don't have to worry about that with them. So if you ever see them out there and I'm not, take a picture and send it to me, and I'll get in contact with them. Right, exactly.
Very good. And actually, I think this is a great segue for this next question. So here we're talking about needing to focus not just on recruitment, but also retention and engagement, and having studies that are welcoming, ready. I think I'm hearing from you, Dr. Thames, culturally responsive. and then how we communicate findings and provide benefits, right? So that we are not perpetuating these kind of really racist ways of doing things in terms of business as usual. So with that then, what's some advice that you would give to our emerging scholars? So we have these wonderful emerging scholars with us today for Black Men's Brain Health Project. And so for those scholars and for all the established researchers, all the community engaged folks at community-based organizations who want to partner with researchers if they have their minds right to do this work, what are some things that that researchers, scholars, and community-based organizations can do together to really incorporate this framework, to incorporate sociocultural variables, and to move this work forward in some of the ways that we've been talking about?
So I would say, the thing I would say to everyone is that when you come together in these partnerships should be just that, partnerships. They shouldn't be vertical. They should be horizontal with minimal, at best, minimal partitions between people. Now, all voices should be heard. All voices should be heard. And in addition to that, there should be some understanding of how you're going to work together in concert to achieve the goal for the better good.
Yeah, I think with great point, Roland. That's great point. I think with the sociocultural level of analysis is a real opportunity for researchers and community partners to work together on qualitative study, right? Because we just don't know enough about these variables in these communities and populations. There's a real opportunity, I think, to propose a project to a funding source to know more about that variable in this population in a geographical local context. So I think the qualitative opportunity is there, particularly for this level of analysis. And I want to double back to the pathological, because I agree with you, going to the community with disparity. But sometimes when you're communicating in other environments to get people's attention, to get them to even think that it's important, you have to remind them again and again and again that these disparities exist, and I agree we need to work on a way to roll that out, in which it's not devaluing communities, but for a lot of policymakers, people who hold purse strings, you have to remind them that these disparities endure and the lack of representation continues, and the treatments won't be relevant unless we do something about it.
I would say I agree with you, Dr. Hill, about there's so much opportunity for you emerging scholars to actually study an area that is, it needs to be built from the ground up, and anything that's currently done, I think, needs to be dismantled in a different type of way. But I would say early in your career, take the opportunity that this is a relatively understudied area, learn how to form the authentic community partnerships that Dr. Thorpe discussed. And as you go up your professional trajectory, I think it's time, if you become a reviewer for a scientific article and they don't describe the sample well enough, or they're making these pathologizing statements without thinking about why is this group having disproportionate more disease, not really investigating the why, I think it's time to recommend that those articles are rejected. And for those of you that sit on study sections, if you go to NIH or one of these other foundations, I think it's time to expect the applicant to have a very thoughtful way that they are going to integrate these sociocultural factors, especially if they're talking about anything related to health. And if that's not happening, that grant shouldn't get a high score. I don't care who this person is or where institution they came from and blah, 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 blah. And for those of you that have grants that are big PIs, don't be stingy about the funding. Give enough money to your community partner so that they can do the work that they have to do, because they're on the ground, they're dealing with the people day to day. They know more than you do about that community. So do not be stingy with the funding.
One other thing I would like to say, and I totally agree with all the comments. Dr. Hill made a comment around the building an argument and a case for the disparities. I think so many times, particularly with policymakers and the people who are going to be able to go in the room to make those decisions, oftentimes we lean heavily on the social and the moral aspect of disparities, and we lean into that. I would also encourage the emerging scholars to think about a business case. How much money do we lose if we do nothing? Because oftentimes we think doing nothing equates to not losing any money. Well, there are dollars of tax associated with doing nothing as well. So the business case can be made in conjunction with the moral case. I think that provides it further bolsters the argument.
And, like Dr. Peggy Dilworth Anderson always says, it's bad science to not
Right.
include
Right.
the populations that are most likely to be affected. That's just bad science, right? So if you want to make an impact on disease rates across, public health broadly, you would improve among those that are most likely to have the poorest outcomes. So.
That's right. So we're talking about economic impacts. We're talking about ethical issues here in terms of incorporating these factors, and also science. So if nothing else is compelling, well, let's talk about the external validity of the data, I hear you saying, and also the internal validity, because if you have poor measures done poorly in the wrong languages, what have you, you're going to have junk data, right?
That's right, Dr. Mint,
Yeah.
Rivera. That's
Yeah,
great. That's it.
Okay, that's it. All right. So I have one more question for our panelists, and I'd like to open it up to our community here today and to our Zoom community as well. So last question that I have, I think last question for y'all is this. Okay, we've been talking a lot about these variables, the framework as it relates to science and research. Okay. What I really want to know, and I really want to know this from each of you. How do we take this framework and the ideas around these sociocultural variables and translate these ideas into care, treatment, and concrete action for public health? Thoughts on that?
I think that I really like the collaborative care models that we've been, using these, and that you have to think outside of the box about healthcare. I mean, we cannot assume that everybody is going to have access to go to the best hospitals and, even transportation, whatnot. We have to go to where the people go that we're interested in helping, from a care level. So if that means that there are screening services provided at the church, for example, or if there are, cognitive screening, services, why not? Why does it have to be in some, center over at UCLA or whatever, which I'm there, I get it. I see people, but the people who I see often they have a pathway of knowing how to get there. We need to have people who are helping guide people through the healthcare process, and people who they trust, not people that they don't know, or who, there has to be people who are in the community. So I think we have to basically dismantle our traditional thoughts about how we think about healthcare, and think about how do we have healthcare in the spaces where people trust and already know and familiar with and visit on a regular basis.
That's right.
Drs. Hill and Thorpe, would you like to add on to that? Disagree?
Oh, so nothing to add. Totally agree.
Yeah.
Well said, April.
Yeah, I don't have anything to add. Put it well said.
That's a great point, because I think it's hard for folks to really understand what it's like if you aren't used to going to those big academic medical centers for care. And those are really scary, can be scary, intimidating places. And, if somebody might feel overwhelmed to go in there for that kind of care you're talking about.
And there's a lot of racism and discrimination that happens. So I wouldn't want to go, if every experience I had going to the doctors was a bad one, then I wouldn't want to go. And I actually know I have family who won't go to the doctor simply because they don't like the way they're treated. And so they just don't go. And I know that Dr. Thorpe, you talked about this earlier, but it's like, you got to have healthcare in a place where people are like, okay, I can come here, it's comfortable, and I can open up about what's really going on with me instead of just taking whatever diagnosis I have and say, oh yeah, everything went fine at the doctor's today.
That's right. That's right. Thank you. Well said. So with that, I want to open it up to questions from the audience here in person and from Zoom.
I'm going to jump in.
Oh, Dr. Turner, my co-PI, what you got to say?
I'm going to ask Harry to come here for a second, please, because I think right in the question that you just asked, I think Harry provides a really nice example of how to do what Dr. Thames just said. Will you talk just a second a little bit about the program that we saw on television?
Yeah, my name is Harry Evans. I am from Milwaukee, Wisconsin. I started a group and I'm moving towards a 501c3 but it's called Heal Black Man. And it's centered around the mental health of the Black man. And I started the rollout by just having a panel discussion moderated by a Black therapist. And I put these guys that look just like me in a space where they were comfortable to have these conversations. And from there, it was just powerful. You know, people were able to open up. They talked about things that they never talked about before, or even if they didn't have those conversations, just to be in the room, they were able to have insight about themselves and self-discovery about themselves to be able to take the next steps to get the treatment that they need. And then furthermore, talking about like kind of penetrating the older men, Black men. Well, not only do you get access to the home from your woman or from the man's wife, but you get it from their sons and daughters. And so now I have these young men asking me, or these men that look like me, asking me, well, what about, like, they say the OGs, or, you know, what about the older men? You know, can we have one where we have the older men in, because now they have this insight about things that is rooted about them, specifically how they were raised, or, you know, what happened in their life early on, to give them, you know, and, you know, a site that bringing in their father, or, you know, their father figures, or the people that helped raise them, that are part of that rooted thing, to unpack those things together and, you know, move forward in a better manner. So I feel like presenting things to people that look like you. So hiring people or having people that look like you go in, you know, look like the people in those communities, go in there and actually, you know, try to get, you know, the awareness. That is the most effective way. Because if you show up in a suit, you know, no offense, looking like you guys, you know what I'm saying? They're, and I don't mean it in any kind of way, but it's real, you know. I mean, I showed up like me, you know what I'm saying? And I think that's what works. That's what works for what I'm doing, you know, and that may be different for every age group, but yeah, that's the spiel, you know. And it's been growing really fast. I started in October, and it's just, I'm almost drowning. So, I mean, I'll say this in front of everybody, I need some help because the media, like, they are really happy about highlighting this, but they don't know what it takes to make it happen. They just like, here, tell your story and bye, you know, and that's not really, you know, that's cool and I'll take the recognition, but, you know, just to be here. So I thank Dr. Johnson for, you know, actually having me here, because they just found me on Instagram just from me posting, you know, what I've been doing, and the growth from there has been, that's the prime example. You know what I'm saying? I guess, so I'm not really here to preach, but thank you. Man, you left me.
Dr. Turner's behind you.
But I don't know, does that make sense to everybody?
Yes.
Am I
Yes.
making a good point?
Yes,
So,
very good.
This has definitely been feeding me, and I
Yeah.
feel like it's beyond divine for me to be standing right here, because I don't think I would have said anything, because this is my first time in a setting like this, but I know this is where I need to be. This is my life calling at this point. So this is the confirmation. So
Wow.
thank you.
Beautiful. That's beautiful. Thank you so much for speaking up and for the great work that you're doing. You, I think, provide an amazing example of what is possible when we stop doing business as usual and really start, you know, connecting with the communities and the folks that we need to really serve and understand. So that's wonderful. Thank you so much. And best of luck with your work. And I also want to note that that work in mental health is so important because when we think about dementia and dementia risk mitigation, there's research to show that mental health and depression can be a risk factor for dementia. And so mental health is an important part of brain health. And so we need to think about these things in an integrated manner as well. Did you have another comment or question?
Another thing that I didn't mention that was like really big was that I wanted to introduce not just having those conversations and being comfortable with opening up about what's going on with them, but also introducing healthy coping mechanisms. So the first thing that I did was just had a Black men's yoga class taught by a Black man, instructed by a Black man, and I just recorded what happened and I put it on Instagram and it went viral. So now I found that there's an untapped market. This is a huge demand because people all over the country are asking, where is this at? I want to be able to do this. And now I'm like, I'm only one person and I want to be able to help everybody, but I need the help.
Well, we're building a community here together for Black men's brain health, and I'm going to follow you on Instagram, and we're going to talk afterwards as well. Thank
right.
you.
Thank you so much.
Thank you. Yeah. All right. Very good. Thank you. Yeah, that's right. That's right. Thank you. Another question?
What's his name? What was your name, young man? Harry. So
Harry Evans.
I'm Tia Delaney, and I represent the Alzheimer's Association. But before that, I'm a registered nurse. And so I'm a member of Black Nurses Rock. And what we did, and I'm from Los Angeles. So what we did in Los Angeles is we realized there was also a community need. And we partnered with Martin Luther King Hospital. So we partnered with them because they had research money, grant money, and they needed research questions answered. And they couldn't figure out a way to get Black men and women into the community, into the hospital setting to get these answers. So we partnered with them and we did blood pressure checks, blood sugar checks, glucometer screenings, I should say, cholesterol checks. And in turn for that, we did them at barbershops and beauty salons. Okay, so we popped up these tents. We're nurses, most of us were Black nurses and female. So to kind of go what you said about how women can relate a little bit better to men. And in order to get this done at the end, they had to fill out the research questions that Martin Luther King Hospital needed. So I'm saying this, you're thinking of other ways of how to grow your
Delaney,
business.
I'm sorry, could you stand up so we could, so everybody could see you as well? Sorry to interrupt.
That's okay. You're thinking of other ways to network for your business is to look at partnering with organizations within your community that focus on health, mental health, or maybe with nurses, and then going into these institutions, as we're saying, that a lot of our community members don't like to go into, right? And see if they have grant money and other things that maybe you can partner with. It's a win-win for the facility, it's a win-win for the community and for your organizations. So start just thinking outside of the box and who you can partnership with, okay?
Wonderful. I love sharing our learnings and our knowledge. That's great. Other questions, comments?
Good afternoon, Brian McGee, social worker, Oakland, California. This is to Dr. Tam. You mentioned going to the doctor. I worked for a nonprofit in West Oakland, California called the West Oakland Health Center. At the time, there was a doctor that started there. His name was Dr. Woods. This was in 1974. I got wind of it. I worked there in 1991 to 99. Dr. Woods was still there. 2022, Dr. Woods is still there serving that Black community of West Oakland. And the trust is still there. My point is there a study where we look at the longevity of Black male doctors in urban communities where generational families are still going to that particular doctor? And what is the outcome? What is the experience? All of that is important because that can be something, a model for not for that community, that county, that parish, that nation. So that'd be a great study. I just wanted to put that out there. Because Dr. Woods is committed to those. He's a pediatrician, matter of fact. So generations that's gone through Dr. Woods. And same Dr. Woods shows up, he shows some love, some caring to family. So we need more Dr. Woods, my point. That's my, just want to say that. Thank you.
Absolutely. It reminds me of, I know that we're talking about brain health, but I was doing a community partnered project with Black women over 50 talking about sexual health, because one of the areas I'm interested in is looking at risk for sexually transmitted diseases later on in life. And it was interesting because a lot of the women talked about they were not comfortable going to the doctor and talking about sex, but the ones that they were having sex, the doctors didn't ask them if they were having sex. But then they finally, a few of the women said, oh, well, I talk to my doctor all the time about sex. And they were like, what? And this, like, we're in this, dialogue group. And she was like, oh yeah, I tell her about everything. And she tells me about this and that. And everyone's like, huh. And it was a Black woman physician who worked in the Black community. And one of our participants was just very fortunate to have that relationship. So she was like one of the few women that had actually spoken to their doctors about sex. So it reminds me, that experience reminds me of what you're talking about.
And that also gets back to this issue of translating the findings in research and how we make that happen in care, right? And move on into public health. So that's a great connection as well. Other questions, comments?
Yes, I have a question.
Yes, please.
Thank you. My question is related to both recruitment and retention as well. Earlier today, we spoke about the different barriers to getting people to be a part of the research that's happening. But we also talked about the desire that the people in the community have to be a part of this research. So my first question is, how do you go about increasing that interest as well as increasing the motivation to be a part of or be involved in the research process when it comes to a participant standpoint? My second part of the question is, once these people are in these research scenarios and they're participating in these groups, how do we develop a support system around them? Because life continues to happen to them, for them, and around them.
That's multiple questions, great questions. Who'd like to field that one?
I got it.
Okay.
You ought to start look on Dr. Hill. So so what's your name again? LaToya. I'm probably not gonna answer all of them. So when I get finished, if I don't answer, then ask it again. So I think, first of all, you raised 2 or 3 very good questions. The thing that I've done in the past is with regard to research process. Before, again, I mentioned earlier in the talk, I said, for me, my perspective, I need to be engaged in the community for about a year, because all of that is building trust and is prepping for the research project that we, collective group, has decided that we're going to do now. It's no longer my project, it's our project. And the success and failure resides on all of us and not just me. Because I've gone and I've developed a relationship, we're going to do it. And the grant just happened to be the mechanism by which we're going to fund our project. And so the money is there now to pay for us, right? Because I've socialized the project in that way. So then we're prepping, and then we're having different town halls or gatherings where we're talking about part about what the study's going to be about, other part about something else that the community wants to hear that has nothing to do with the science at all of what we're going to do. It's a partnership. It's not a totalitarianship. And that's oftentimes what happens. And so I've learned through that, preparing that and doing that takes some time, but it helps as it relates to the research process, because all along the potential participants are now feeling like they're engaged. So when it's launch day, when the fanfare comes on launch day, it's not that difficult to get people to start enrolling, because I've created this space where we're working together in a true collaborative space. And your second question was, how do we keep them engaged?
Regardless of that person being a part of this process.
Yeah, so how do you build a support system around it? So once they're enrolled in the study, we have put retention money in for the study. And then what we think about then is, what is it, as we're going through this process, we're steadily engaging them, and we find out there's some things that they need, and we try to address those within the confines for which we can spend that money, right? And then if it's not that money, then I'm constantly trying to think of, are there any other pots of money that we can work in? Because let's just call it what it is. If you got to have resources to go into the community, you got to have them. You cannot, it won't work. Otherwise, you got to have money or access to money. And that money doesn't always come from the PI. Again, it's a us thing at that point. It's no longer a rolling thing. It's a us thing. We're all in this.
That's right.
We're all in this together. And you have one more question? Am I good?
He got a thumbs up from Latoya.
Oh, look,
Okay.
yeah, I'm ready to
He
go.
got a thumbs up.
Now, I know Carl want to ask.
Dr. Hill, Dr.
Well,
Hill.
no, I was just gonna say,
Go ahead.
these are great best practices from Dr. Thorpe, but these are empirical questions, that
Yes.
I think are locally determined. And so, I got this phrase from my colleague, Dr. Louis Medina at the University of Houston, but this is the science of inclusion. It means that in addition to your research project, you've got to evaluate strategies for recruitment and retention and support that may be different in North Carolina than they are in Atlanta or Tampa, and that should be a part of a project, that's funded by the funding source, to understand how best to recruit a population in that local geographic context.
Great point.
Right, and I think the evaluation is no different than the evaluation we do now, process and outcome, all across the thing. Those process and outcomes as they relate to recruitment and retention. I think it's a wonderful idea, the science of inclusion. I'm gonna move forward with that. Thank you, Dr.
Absolutely. And this is great foreshadowing for our workshop tomorrow, because tomorrow, Dr. Thorpe, myself, and our wonderful community member, Dr. Williams, Dr. Lamont Williams came in from North Carolina today. We're going to be talking about the how-to for community-based participatory research from the perspective of community-based researchers and from a community perspective partner. And we're going to be breaking this down in more granular, kind of nuanced strategies for community members and for researchers tomorrow. So also thank you for that interest in that, in that area. And I think we have another question. Is that right?
Yes, one more question. Thank you, everybody. My name is Lawrence. I have a question about, it seems to be a disconnect. Everybody in this room, I think we all can identify the disconnect between academia and the community, right? So how do we recruit people that look like us to do research? I think, I don't know, I'm a young Black man from my community. I don't know anyone else in my community that is in research from my community that is actually a research coordinator or a project manager or a PI even. So how do we, and Dr. Thorpe, your presentation about social determinants of health that Black men face, I think that's important. Like, how do we, I can identify with that, but a lot of people in the community can't articulate those things, right? You have to kind of be from there to are able to articulate those social determinants of health. So how do we recruit and retain people that look like us to be researchers and to work at UCLA,
Right.
UCSD, USC? How do we do that?
So can I jump in here really fast, Dr. Thorpe? I just want to.
No, please.
Yeah,
I don't, you're running the show.
That's right. Well, I want to, but you're the panelist. You're the panelist. Y'all are number one. Y'all are number one. But I want to ask our emerging scholars to wave their hands right now, right? So in this project, we're trying to address that leaky pipeline by supporting the research and providing mentoring for future scientists or emerging scientists to get through to do this research that we're talking about in the right way, because they're learning how to do community engaged research, to partner. So Dr. Thorpe talked about socializing his lab so that they get this idea of doing work this way. Well, we're training the next generation of scholars to also know how to do this work right in the community, to also inspire other community members like my cousin, my brother, everybody around, so that this isn't something that's separate. This belongs to all of us, right?
I guess another question I think I have a follow-up is, what are the qualifications to do that? I mean, you mentioned what education is valued, right? So you have to have a master's degree, you have to have this kind of education. Is that something that should be required, or can a research coordinator come in and be a person off the street? Like, what are your thoughts on that?
So, may I, Madam Moderator? No, I'm just joking.
Yes, you may, Dr. Thorpe.
See, we're so cordial. No, I hear your question, and I totally get where you're going with this, and I want to applaud you for the persistence. To answer your question, to become a research coordinator, I don't think you need a master's degree. I think what you need for me, and when I'm hiring people, I'm not hiring for what I'm looking for your potential, and I'm looking for a pipeline. Is what a pipeline that doesn't leak. That's what I'm looking for. And I start with my training. I start early as undergraduates to talk about what are the benefits of science, what are the benefits of being in research, what are the different types of research, and show them that it's cool to be in research. It's cool to think about the research process, right? Because again, it go back to my little marketing rule. If you don't like something, how many people you tell? Tens of thousands if you don't like something. So I think it's engaging them early on. And I think you can, if you want to aspire to get a master's degree to do it, you can. But where I work at Johns Hopkins, there are research coordinators that don't have master's degrees. There's research coordinators that don't have bachelor's degree. But a lot of them that have come through and participated in research projects and grown and got the training and grown into those positions. So yeah, I don't think that you have to have a master's degree. In fact, I'm not looking for someone with a master's degree. I'm looking for someone who has the potential and someone who wants to join a team that can be a team player and check your ego at the door and say the greater good is Black men as a whole. And my instance is Black men as a whole. That's what I'm looking for. But different people who are looking for different research coordinators, maybe look at something different. You shaking your head like you don't believe it.
No, I completely agree. I don't look for someone with a master's degree or even bachelor's degree. I've mentored a lot of students, over time. And what I look for are the same things that Dr. Thorpe just mentioned is you want someone that is committed and someone, because it is hard to be a PI of a lab. There's a lot going on administratively. And it can be a lot of pressure in the academic settings. So you want people that are reliable and really committed and love the work. So if I sense that someone is not in love with what it is that we're working towards, then I'm not interested. I don't care if they had a PhD walking through the door. So
That's right. That's
And
right.
so one other thing is that now to go back to the education piece, I'm not pushing it, but if you come to me and you work in my lab and you commit, you say, hey, you got a bachelor's degree, I want to go get a master's degree, then my conversation is great, cool. But let's see how we can find somebody else to pay for this.
That's right.
Now let's go
I
on
was
and
just gonna say
circle
that.
out and get somebody to pay for this and get you where you want to go. Because I personally feel if I'm doing my job, I expect you to leave me and go somewhere else and do better.
Yep. Very good. Dr. Hill, did you want to add anything to that? Okay. Very good. I think we
All
had,
right. We just have, I know there's several folks that have
Oh, dear.
questions. I want to get to one from the virtual before we
Okay.
break. So one of
Okay.
our attendees asked, how are you using the clinic to community modeling and translation research theory to transform policy and research into community action so that the most vulnerable in the community gain access to services, resources, and clinical trials?
Yeah, that's pretty long one there, but I will say from the Alzheimer's Association's model for delivering our resources, through the chapters to communities that are underserved and disproportionately affected, we prioritize, as I mentioned earlier, partnerships, working with the African Methodist Episcopal Church or Omega Psi Phi Fraternity Incorporated to link, local entities to deliver our content in a culturally appropriate manner. So the focus in our space is partnership, but we're not recruiting individuals to clinical trials. So
Right.
it's different.
Yeah. And the Alzheimer's Association has been a tremendous champion of this translation piece into the community. As disclosure, I'm also on the board of the New York City chapter of the Alzheimer's Association and to see and practice what they do in terms of providing caregiver resources, education, consultation. It is incredible. It's something to behold. And I'll also say that the CDC has been recently active with some initiatives to try to translate some of this more community-based work and issues around dementia risk mitigation, so that in one project associated with the Alzheimer's Association, OLD, right? We're in that project, and I'm also contributing to it. We're developing public health guidelines to disseminate to local, public health, county public health institutions all over the country, so that we can take a community-based, culturally responsive approach to getting the word out about some of the things that folks can do to reduce their risk for problems with brain health, reduce their risk for dementia. But that has to happen in partnership with, community members for that to work. Anything else? Good. Okay, so I want to thank our wonderful panelists, Dr. Hill, Dr. Thames, Dr. Thorpe, for this great panel, and especially all of you here for engaging in such wonderful dialogue, and folks on Zoom for also sending those questions. And we'll try to follow up on additional questions we didn't get to as well later. Thank you very much.